completed 50 of these excellent panel discussion webinar conferences, predominantly started at the time of when the pandemic had started. And we have since tried to bring the world together, as so to say, all the regions, trying to bring to understand what each one's going through, as all of us together, we realize taking this pandemic, we're all in it together, and we are sure that we'll all come out of it together. So, a very good day to all of you. So welcome. And now we're going to start this webinar, and I will, as I usually do, I will ask Dr. Mary Matthew, Professor Mary Matthew, the co-chair, to also welcome you and say a few words.
Thank you, Dr. Russell, and good day to all. And it's lovely to see all of you back once again. This 51st webinar is a very interesting webinar. We are going to talk about what has happened. So we are looking backwards and what we can look forward to in the future. And of course, bringing in the idea of solidarity, which has kept us going through these 51 webinars. We have very eminent speakers today, and many of them have been on this panel before. And I hope we have a fruitful deliberation and discussions today. So welcome to all. We have shared the YouTube link in the chat box, so you can share it with your friends. And as usual, please put your questions in the chat box if you have any. So thank you very much. Over to you.
Derek, can I welcome Professor Derek D'Souza, who is the coordinator and of the chat moderator, who will also welcome you. Over to you, Derek.
Thank you, Dr. Russell. And really, it's always wonderful to see everyone here is quite familiar, because you all have been on more than one and been with us on this journey, bringing us up to 50 and beyond. And that's why we thought it's a nice time to stop for a minute and take stock of the situation, because thankfully the situation is quite different all over the world. So it's given us a little bit of time to maybe breathe and plan ahead as well. And that's what we would like to see. What can we learn from each other, and what are the lessons that we could take back from the past experience of the year and a half that has gone? So please feel free to put in your comments or even questions that you have into the chat box, so that we can put them to our esteemed panelists. We don't have that formal discussion today, so it covers all aspects of our experiences, and we would like to hear from each other. So you may put down your experience into the chat box. You can put down your question if you would like it to be addressed to any of our esteemed panelists, and we will get them to answer it for you. There is also in the chat box the link to the live stream on YouTube of this webinar. So please feel free to share it with your friends, with your peers, anybody else who is unable to log in via Zoom. And also the recording of this webinar will be subsequently available there as well. So if you would like a recording, you can always visit that link, and the recording is free to download from there. So thank you, everyone. Good to see you all. Looking forward to not just a wonderful discussion today, but being with all of us on this journey ahead. Back to you, Dr. Russell.
Yeah, thank you, Derek. Now, as you said, this has been a program of the Department of Education, the international program of the Department of Education has been organizing this for the last 18 months or so. And we've had, we've covered many areas, every discipline, even health economy, economists and so forth have come in, and law and so forth. So this has been, and of course we have, as Derek said, things, this is an opportunity to look back. When we started, what were the issues? Where are we up to? And how do we go? But more importantly, underlying all this is the solidarity that we have been able to bring forth. As you will see, our participants that you'll meet here are from every part of the world, and I'm delighted, from every region of the world. I'm delighted to actually have this and share this all the time, bringing the world together, as it were. Today, we have every one of the panel members have been on this program more than once, more than twice. In fact, more than over the last 50, they've had directly, indirectly, they've been all involved. And just for you to, I think a couple of panelists are still to join us, but we are almost covering all the regions of the world. We have North America, we have Canada, United States, we have Canada, we have the whole Latin America represented, and the Caribbean. We have certainly South Africa and East Africa, and that Kenya, the president of the South African Medical Association is joining us. And we also have United Kingdom and Europe, and of course, India and Hong Kong, China, Hong Kong. So we have these very distinguished members here who are part of the council of the of the organizing committee and so forth of the Department of Education. So let me, I'm going to ask two people from our council to say a few words on this program. Two of them, I'll start with Dr. Ravi Venkatesha, who is the treasurer of the World Medical Association. Now, he and Dr. Ottmar Klobers have been involved, the Secretary General of the WMA, from the first two. They have been regularly coming in on several occasions. And of course, as you know, the international chairs also know we have a collaboration, cooperating with the World Medical Association. And of course, many of the others here are also members or have represented their medical associations in the world, in their countries. So before I go further, I want to I welcome everyone. I want to acknowledge some of our colleagues who are here. Professor Geeta Lakshmi, the Vice Chancellor, who has been a key to many of the programs. There is Dr. Arul Raj, who is the President of the Association of Physicians of India. And I think Tara is there. Yes, Dr. Geeta Lakshmi, welcome. They've all been here. Thank you very much for joining. They've all contributed significantly to this program.
Dr. Deborah is also there.
Yeah, Dr. Deborah. Oh, yes, there's Deborah. Dr. Deborah from Brazil. Again, she's part of and Dr. Tara from Kurdish region of Iraq. These are all part of our program
Dr.
here.
Miriam.
And Dr.
Miriam is also there.
Yeah, well. Dr. Miriam from Nairobi, director of nursing. So we have like this from all over. You'll see Dr. Katrina also from Brazil, I think. So a lot of welcome to all of you. We're very happy to have you continuously there. A big welcome to all of you. Now, before I go further, let me ask, I'm going to have two very distinguished colleagues or members of our council who are going to say a few words before we start. One is Dr. Ravi Venkateka, who's, I told you, the WMA treasurer, but also the president of the SAC Medical Education, Medical Association. SAC represents the countries of South Asia. And Professor Baroness Professor Elora Finlay, as you know, she is on our council. She was the former president of the British Medical Association, and of course, professor at Cardiff University and a member of the House of Lords. So these two have been involved and virtually right through these 50 sessions with. And so I'm going to first ask Ravi, as from the World Medical Association, to say a few words, to give your thoughts, Professor Ravi.
Thank you.
He's a surgeon. He's also a surgeon. Yeah, Ravi, can.
Thank you, Professor Russell, Dr. Derek, Professor Mary, all the distinguished and eminent panelists and guests, and all delegates who have joined for this very unique and important webinar. First of all, let me thank on behalf of World Medical Association, Professor Russell, Professor Derek, and Professor Mary, and their entire team. For last 1.5 years, you have been doing an excellent job. And this is the 51st webinar. Really, you deserve a lot of kudos and a lot of congratulations. As you are well aware, WMA, the World Medical Association, always puts ethics on its topmost priority. And hence, we have collaborated with the International Chair of Bioethics to promote ethics throughout the world amongst all the physicians of the world. And also, I am very happy to say that this team of Professor D'Souza, Mary and Derek, they have worked wonders in this time of pandemic. And whatever today's topic is, the global solidarity, and to take a stock of the situation, because we have got a breather now. But through these webinars, the real solidarity amongst the physicians, exchange of knowledge, exchange of experiences, and coming out of solutions from that deliberations and discussions are a unique features of these webinars. Today, when we think what we have learned from the entire pandemic, when countries are at different stages of pandemic, countries have entered 5th, 6th wave, and we in India are waiting for the 3rd wave. One thing is very, very clear, that the health systems, no health system is found to be perfect in dealing with this pandemic. May it be the most advanced countries spending huge amounts of money, or the poorer nations, or the developing nations like India, where the spending on the public health infrastructure is not up to the mark. All have struggled to cope up with this pandemic. And in spite of the health infrastructure not able to cope up, one should congratulate the remarkable work done by the frontline health workers, including the paramedical staff and the nurses and the physicians, who risking their life in spite of inadequate resources have really given their best shot. And this underlines the importance for the various governments to be prepared for not only the coming waves of this COVID-19 pandemic, but as everyone is aware, that last 10 years we are seeing waves of pandemics coming, may it be MERS, may it be SARS, may it be Ebola in a limited geographical area, but as more and more damage is done to the climate, and climate change is affecting the environment, and we are encroaching onto the forest, or to the more interaction between the wild species and the human beings. Such pandemics, especially zoonotic pandemics, are going to be the norm of the day. And hence, whatever new normal as per the country specific, not only the healthcare workers have to be ready for it, but more importantly, as today's theme is rightly so, we need to have a global solidarity. As everyone is aware, the global inadequacy regarding vaccination, which has been a stark contrast that certain countries are going on to booster dosages or third dosages, while majority of the population of this world is yet to receive a single shot of vaccination. The supply chains, where we thought that this has become a global village and supply chains manufacturing anywhere, we can provide it on any corner of the world. This model also needs to be reworked. We need to have a local production, but having a global solidarity, especially in terms of sharing of technology. The waiving of patents in such pandemics should be the new normal. And more efforts, though efforts through WHO, through COVAX, for vaccination purposes, for sharing up of investigative technologies, but I think they are too far inadequate, and hence the entire systems would have to be reworked, revamped, so that no one in this world would suffer due to lack of resources, lack of medicines, lack of vaccinations. With these few words, I once again congratulate the entire team and hope the collaboration between WMA and the International Chair of Bioethics will flourish, and we will continue working together for promoting not only ethics, and ethics did play a very, very important role in this pandemic also. And that is one aspect also which needs to be reworked, because you can't have unethical behavior in the name of pandemics. So thank you once again. Over to you, Professor Russell.
Thank you, Professor Ravi. Thank you very much, and thank you on behalf of the World Medical Association for your support and continuing working along with us. And we'll come back to the panel when Professor Mary moderates. We'll come back to some more discussion there. Now, let me call on the very distinguished Baroness Professor Elora Finlay, who is from United Kingdom, was the past president of the British Medical Association and council, and very important part of this program, head of the United Kingdom unit of the International Chair of Bioethics, and has been involved with this program right through from the start to now. So can I invite Baroness Elora Finlay to say a few words on her looking up and looking at what has happened over this 1.5 years. Over to you.
Thank you so much. Thank you, Russell. And may I thank all of your team, particularly for all of the IT support that you've had and the chairing support and superb chairing by Mary over the whole series. I think that the series was actually very important for us all. And as we reflect on it, I would like to divide that into 3 particular areas. One is what we've actually learned from the pandemic itself, and how we take that forwards. Secondly, what we see as other global threats coming along, possibly outside of infections too. And third, really, what have we learned from all this in terms of the role of doctors going forwards? So if I look at the pandemic, first of all, obviously preparedness was a big issue. And as it turned out, I think no country was really adequately prepared. But what we did see was the importance of science and the rapid move towards understanding mode of infection and then developing vaccine. And that was down to rapid investment by governments in scientific endeavour and supporting scientists to move forwards very fast. And that meant some of the previous bureaucratic processes were abandoned. And I think there is an important lesson there, which shows that people can move forward fast. Now, there was a downside, of course, because the anti-science movement seemed to gain momentum. And in some parts of the world, infection control was somehow viewed as if it was some infringement on personal liberty. And I don't think that that's something that as doctors we can ignore. We have a duty not only to the person in front of us, but we also have a public health duty. And to not try to do something about educating the public better, that their freedoms depend on the freedoms of other people too, I think that we will fail going forwards. There are people protesting about vaccination, but there have been people protesting about very, very simple things, such as wearing a mask, which really doesn't inconvenience anybody, but was shown to cut down transmission rates. So I think one thing that we've learned is that we need to be prepared to tackle that head on and not skirt round it, but also make sure that good scientific advice is going through to governments at every level so that they continue to recognise the importance of medical science in the whole security of the nation that they're responsible for. The next area that I want to look at is emerging global threats. And whilst we've been very aware of infection, I would remind you all that, of course, we have the COP26 summit going on. We have the climate summit happening in Glasgow, which is not very far from me on the global scale. It's a few hundred miles away. We have had some terrible wars emerge with severe water shortages. Climate change is bringing around a change in water distribution as well. So areas that were subject to drought may be now subject to intermittent floods and severe storms. And if we don't tackle climate change head on and take that as a personal responsibility of everybody, then all of that will get much worse. And we have seen that the outcome of wars is absolutely disastrous. The estimate is that 50% of the population in Afghanistan are now potentially starving. We have refugees who are escaping from different regimes around the world, but no country seems to really want to give them shelter. And I think we do have to look very hard as doctors in particular, what we do to support other doctors in other countries and what we do to persuade our governments that actually we have a humanitarian duty in the face of humanitarian disasters. And the third area that I want us to think about is very specifically the role of doctors. I've already spoken about medical science, but I think during the pandemic, it really emerged that the duty of doctors is to support life, and that the outcome in any clinical situation cannot be judged 100%. We cannot say somebody's prognosis is definitely bad, so bad that they will be dead with any degree of certainty over time or outcome. There have been some really surprising survivals. There have been some tragic deaths. There have been deaths amongst doctors themselves who caught infection and died in the course of duty. And we do need to make sure that we recognize that our role is a public health role, both towards our own staff to make sure that they minimize their risk of infection or other injury in any global threat that we're coping with, but also that we recognize that the default position that we should have is to support life, but that we must recognize as well in that where resources are limited, we have to use resources to the best advantage that we can. So there's no point pushing ventilation of somebody who is clearly not improving, and in the process deny that piece of equipment to one or two other patients whose chance of survival is really quite good if they were tided over a crisis. So the whole ethical debate and how we tackle those pressures, I think, has come to the fore as well. And that's why I welcome these discussions, because I don't think that we've ever shied away in any of these seminars from recognizing that there really are difficult decisions that people are taking every day, that they are weighing them up in that scale pan of benefits against risks and burdens. They're weighing them up for the individual and for the population that they serve. And that many doctors have been working with very limited resources and have had to cut corners, do things differently in order to serve the largest number of people that they can in a situation that was extremely difficult. So I think in a way what we've learnt is that medicine globally is the same, that doctors' duties are the same. And I would suggest that the voice, the united voice of doctors together, is far stronger than any one individual group, and that we must maintain our science and our medical science roots at the forefront of actions and push those boundaries forwards, because that's where we will be able to make change and be better prepared next time round. So Russell, those were just some reflections I had in those three categories. And again, I'm most grateful to you for having promoted the discussions, because I think it's empowered us as well when talking to our own governments, that we've had a view of what's been happening around other parts of the world. And certainly I have quoted some of the things that I've heard on these webinars in discussions I've had with ministers, and it has been most helpful. So thank you.
Thank you, Elora. Thank you very much for that. For all of you to know, I might have to have said, Professor Baroness Elora Finlay is also she's a member of the House of Lords and takes a very active role in the British UK government and in many of the health decisions that have taken place. So thank you very much for that. Now it's I'm going to introduce to you our panel today, and then so that and then we'll move on to discussion with Professor Mary moderating this. Let me welcome and thank the panelists, and let's start with Dr. Lincoln Lopes Ferreira from Brazil, who is the president of the Confederation of Medical Associations of the Latin America and Caribbean. She's the Caribbean. He's also a surgeon. And welcome, Dr. Lincoln, and thank you for joining us, and thank you for your support and coming on this program many times and representing another large region of the world, the Latin America and Caribbean. Now, let me also then, we've acknowledged both Dr. Professor Baroness Elora Finlay from the United Kingdom and Professor Ravi Venkateswara from India, but he also represents the SAARC region as the president of the SAARC Medical Associations. Then we have Professor Joseph Thornton, who is from the University of Florida in United States. I want to welcome Professor Joe Thornton, and thank you for he was there for the very first webinar, if I remember right, and has been there several times. So thank you very much for your contribution all along. I'll also now introduce to you the very distinguished Professor Shabir Amanullah from Canada, from London, Ontario. He is the president of the Geriatric Academy of Geriatric Psychiatry in Canada. And is a member of the Department of Education faculty and organizing committee member here. Thank you. Welcome, Professor Shabir, and thank you very much for your contribution for us reaching our 51st webinar today. I'd like to introduce to you the distinguished Professor Alvin Chan. Alvin Chan is from Hong Kong. He's from the Hong Kong Medical Association. He's also the treasurer of the Confederation of Medical Associations of Asia and Oceania, and he's a pediatrician. Dr. Professor Alvin Chan has been with us several times and has contributed from Hong Kong and China on this program. So welcome and thank you, Alvin, for your continued support here. And I'll also now welcome the very distinguished Dr. Angelique Kotze, who's the president of the Council of the South African Medical Association. Dr. Angelique has been on the program, but she has been regularly making sure that South Africa has several very distinguished colleagues from South Africa, including the last one. We had the head of the CEO of the National Medical and Research Council take part. So thank you very much and welcome to today's webinar and as a panelist here. And then finally, I want to welcome Dr. Leon Ogeti. Dr. Leon Ogeti is the convener of the Public Health Committee of the Kenyan Medical Association. He represents the Kenyan Medical Association here in this program, has been on this program and has regularly made sure that we had East Africa represented on our program. So with that, we have, and of course, Ms. Jasna Karachik she's from the patient ombudsman of the European Union and moves across Croatia, Italy, and Belgium, and she has been on the committee and has been regularly here. Welcome, Jasna, and thank you for your contributions to this international program. So now I'm going to invite Professor Mary Matthew to lead this important part where we're going to look at our panelists and take this discussion further so that we will all benefit. And one important part of all this is the global solidarity. You would see we virtually have the region, I of course from Australia. So all the regions of the world are generally represented, and we get to build that solidarity, cooperation, and ultimately making sure that we are all telling all of us that we are all in this together and we will definitely come out of this together. So thank you all very much, and let me now invite Professor Mary to take over the moderation and the discussion.
Thank you, Dr. Russell, and good evening to all, and good morning and good day to all. May I request all the panelists to switch on their cameras so that our audience can see you all? Yeah. So thank you very much for coming on to this session. This is a session where we are going to look back and look forward, and hopefully have some plans for the future. And we are going to discuss it globally, and we will start with Professor Dr. Lincoln Lopez. Dr. Lincoln is from Latin America. He's the president of Confederation of Medical Association of Latin America, and he has been with us for very many webinars. Dr. Lincoln, may I invite you to speak now? I cannot see you. Yeah. So, Dr. Lincoln, please give us your, I can't see you on the screen. Dr. Derek, can you please pin Dr. Lincoln?
I'm here.
He's pinned.
Okay.
Hello.
Okay, thanks. Yeah, there you are. Okay.
Can you hear me?
Yeah,
Yes,
we can
absolutely.
hear you now.
Well, very nice to meet you.
Yeah. Thanks.
Okay, can I speak?
Please.
For sure. Well, first of all, my greetings to Professor Derek and Professor Russell, and also for you, my dear colleague, Dr. Mary, for this 51st meeting. And it is an honor for me to participate in some of them, representing this vast region that is the Central American, Caribbean, South American, and Iberic, Portugal and Spain are joining us in the CONFAMEL. As we are a very vast region, for sure, we are a very heterogeneous region. So to speak on this point of we're discussing today in a very synthetic way, I'm obligated to touch a lot of points without being very explicit in order to talk about what happened here. We start with the pandemic in different systems, well developed in Portugal and Spain, well developed in Uruguay and Argentina and Chile, medium developed in Mexico, also medium developed in Brazil and Colombia, but the different level of the development in the remaining countries. So there's a lot of not very good things that happens. A lot of casualties observed in our health personnel. We start a lot of positioning or letters to government in order to evaluate and protect health workers. In Nicaragua, particularly in the last WMA assembly now, we had a motion because doctors there and work health, they were treated as a criminal just to assist people. They are protesting in the street, they get wounded. So they're just assisting wounded people without taking into consideration its responsibility. The responsibility is a legal thing to see in a different level. But these people they're supposed to be criminalized. So we really don't agree with this thing. Another thing that we performed here is to discuss the medical formation. There's a lot of schools here in our region that are seen just on the economic point of view, that they don't take care a lot of the quality of the substantial to have a good doctor in a human, in an ethical, in a technical way. So I've traveled to Bolivia and Uruguay in order to talk to the government of these countries and to put together a different stage, a different level of the education of students. We achieve it now with the help of our colleagues from Spain and the medical specialist society. We join to make a deal with them in order to recognize all the course, all the specialization, all the steps we performed here in Latin America in an international level. So it's a thing that will be good because in the future, all the people from good and the standard schools, medicine school, and also the thing that they are promoted in order to specialize colleagues will be internationally recognized by this agreement with the European Specialist Medical Association. Well, another very important thing that happens here, with Uruguay, we in Brazil, we had 6 twin cities. And one of them particularly you see the street, and there's an absolutely common street, normal street, but in one side is Brazil, the other side is Uruguay. That means in one side is Rua, that's street in Portuguese. The other side is Calle, that is street in Spanish. And together with the health ministry of both countries, our medical association with both countries, we have a meeting and we start a very successful program in these cities in order to control the pandemic. Very successful. It was a very amazing and very good experience we planned it. Also, we had the problem, or not the problem, but we had the question of vaccine. As Dr. Ilona have mentioned, a lot of ethical issues, a lot of discussion that brings politics in order to this already big sanitary catastrophe. So we must treat this or try to treat this only in technical and scientific way. We had some problems to access and vaccine. We had some problems to distribute them. And also we had the problems of discussing people, like in instance in Paraguay, they refused to be vaccinated because they thought it's just water, or they cause harm to them. I think it is stopped now. We had it in different levels, luckily. And finally, just looking to the future, well, when we're discussing in our countries here, the level, the improvement or the formation of the new doctors. They prepare them to the 21st century to, of course, to treat the COVID-19, but also to prepare them to prevent another catastrophe like that. And I finally say that in the next week, we had the participation in the integral initiative of the Colégio Médico de España, the Medical College of Spain, that is integral care program for the sick doctor. As a lot of, as what happened in the rest of the world, a lot of problems, or physical or mental, had resulted for those who went to the field of the combat of COVID-19. So I think in a few words and without being very specific for each theme, I must not forget the colleagues from Mexico. I participate also. They had an initiative that show us COVID as an accelerator of the future. That means such a crisis like that, it allows us to discuss like telemedicine, like new technology of vaccines, like new treatments, with a speed or with a preparation that we don't have in, I would say, normal times. So it impressed me a lot. And the question is, in your view, what will be the world in 2026? And it's amazing how different ideas, how different propositions appear on this thing. So it's a reason of, I think, of course, limited because it came from my vision that as a human being, always limited. But I think there's the thing that happened here in South America, and I finish saying that I think it's very rare that we as a species, as a human, we face such a global problem in such a common ways. So it brings us in face of ourselves and say what we want as a species, what we care, we must take of of every each human on the earth. The question of respect we must have to different point of view, different way, different levels of social organization. And finally, the ethical issues about vaccination, distribution of vaccination and access of good health to everyone. So thank you very much for your attention. Of course, I'm open to all the questions that I can answer. Thank you very much once again.
Thank you, Professor Lincoln. It's lovely to see that what came out of the pandemic was more of collaboration and upgrading of the skills of the doctors. And more importantly, India also had the same problem where doctors became the victims of violence, and they were subjected to a lot of mental harassment. It's nice to see that you all have taken the initiative to support doctors, especially with regard to mental health. Now, I'm taking Dr. Tara's question from the chat box and putting it to you. Do you think the society has more expectations from the doctors now? Because on one side, they're getting beaten up, and on the other hand, they expect doctors to be everything, do everything for them.
There's like most of the thing on the life, there's a lot of positive points on this actual situation and some negative. Positive point is, yes, we are now in the target of discussion of our societies. It's possible to start here in Brazil, particularly, for the first time in a national career, medical career, in order to let people go to very remote regions. It's like these oil platforms in the sea. That means we can just say that the doctor will set in the very far, a little town or very far away, and we spend a lot of time with the rest of this professional life over there. People don't say. It's curious. One day, one friend talked to me that we are doctors. We love to be to cure. We love to see people very well, but we can't stand being a part of scientific progress. So when you send generally a young doctor for a very far away distance, a very isolated place, you must give him scientific information and work.
Support, yeah. Scientific support.
Yeah. So this exactly this point is now in discussion in our region. The other side is that I always say that the lack of doctors, and it is curious. Brazil alone is graduating now 35,000 doctors each year. And I think we are second in the world in medical school, only after India. Yeah. And there's about 100,000 Brazilian students now in schools of Paraguay, Bolivia, and Argentina. And so it is curious to say that they say there's a lack of doctors here because, in fact, we are now about 650,000 approximately. So it's a very huge population. The problem is the conditions of work, especially in these faraway regions.
Yeah, but most of them would also migrate to other wealthy countries, Professor Lincoln. That is what happens. Even though we are churning out a lot of doctors, many don't want to go to places that are remote or would like their future to be better. So I think we are losing out. It's a brain drain, actually. And that is where...
If you allowed me, it is curious. I think it's a phenomenon that happens in countries that share common languages. Not a lot of people in Brazil speak in English.
Okay.
See? So speak Portuguese, we're related to Spanish. And there's for sure a lot of people that go to the United States, Canada, and Europe. But especially in Brazil, there is not a high percentage. In fact, a lot of people from Bolivia and Paraguay, especially they come here to work here. And of course, they are welcome.
So the problem, Professor Lincoln, is Paraguay loses and Brazil gains.
Yeah. No, in Bolivia is a huge problem. I've been there twice. It's a huge problem. I agree with you.
Yeah, that's right. I mean, it may not be to USA, but then they're coming into wealthier, South American countries. Yeah. Thank you very much, Professor Lincoln.
Thank you once again. Thank you all for your attention.
Yeah.
Thank you.
Professor Joe. Professor Joe Thornton is from USA, from the University of Florida.
Okay, well, thank you, Professor Mary and distinguished panel. I had written out a few words that I'm not able to share, so I'll try to speak clearly. I'll start with my conclusion, and most of what I say just hopefully will be reinforcing for what you've heard and will hear. I have three main points I wish to share. Well, the first is I think with COVID, it's safe to say, and I started this after the Ebola epidemic, was that all epidemics are behavioral. That it's our behaviors, how we interact with each other, how we organize our resources, how we organize our responses, are what contain or perpetuate an epidemic. And that's certainly been magnified with COVID, because you could argue we could be much further ahead if we had common, more effective behaviors. Second, and which is the main theme for our conference, is that our behavioral choice, I'd like to expand, it's not mandate versus non-mandate, it's solidarity versus government mandates, at least in the United States. We've lost a lot of ground in efforts to strengthen the response. We've inadvertently lost ground because people who agree with vaccination, agree with masks, agree with containment, will be opposed to government mandates. And also the government mandates and the consequences that are imposed creates a residual resentment and more divisiveness. So it doesn't accomplish here what maybe had been hoped for. It becomes a power and control struggle. Then finally, final point for me to make is that as we look at threats ahead from COVID or other pandemics, I will present that the greatest threat comes from AI, meaning artificial information. So we can sometimes look at the same data points, but because of our education background, our biases, we interpret them differently and behave differently. And then when you add on that, people use information for power. They'll distort information for the purposes that they present it. So we have to learn a skill set, and as Baroness stated, we need to participate in educating the public on how to interpret information so we can accomplish and behave what we're expecting to. Real quickly, reviewing what we've experienced here in the United States, our first response was, as a physician in an academic center, I would say was denial. It was a China problem. And so we sort of said, we'll let them deal with it. Then when it hit the United States, it was a Seattle problem and a New York problem. We saw it go to Korea, we saw it go to Italy, we even saw it go to the UK, but we didn't respond. It come to Seattle and New York, we say it's their problem. It really wasn't until it came to our neighborhoods that the epidemic was our problem. What we did experience initially was the uncertainty and the evident lack of preparedness. So even though we had relatively small numbers in March and April of 2020, we exhausted our PPEs very rapidly, and we weren't able to take care of the patients who were presenting for care. And that was a huge stressor and a huge fear factor. By time, even before, once we got more supplies in May, our societies partially opened up in different areas. I live in a state that's sort of what you call a red state, a very open state. So they went back pretty close to normal in summer of 2020 when we then experienced a significant wave. of COVID, but we just sort of dealt with it because the hospitals were still functional. And then we were also distracted politically because that's when the Black Lives Matters and the institutional racism really took head. And plus it was an election year. Then we get into the fall and we have all the turmoil around the election as the epidemic is peaking. And it really peaked at the December of 2020, January 2021. But at that time, we had hope with the vaccine. So we were really at our lowest point in December and January. Our politics were the worst. Our despair and struggles with COVID nationally were the worst. But we had the hope of the vaccine. And as the vaccine was distributed, we did see immediate relief in the decrease in number of cases, people coming into the hospital. We also started learning more about how to manage COVID. So as we get into the spring of 2021, we sort of then turned a corner where people wanted vaccines, got the vaccine. Then we ran into this larger than expected residual who were resistant, not only to the vaccine, but to efforts to control the infection. And that's where the disinformation really harmed us. And we had another peak with the Delta wave, which was really an epidemic of the non-vaccinated. That's how it's best described, and still continues. The worst is over, but it's still hot pockets in the U.S. So it affects a selected population. But we've learned a lot more about managing COVID. So our case mortality rate for hospitalized patients was over 20% when they were hospitalized. Now it's closer to 10%. And when you look at the case curves in the daily death rate, you find that it's dropped a great deal. So we know more about timing of drug treatments. There's a different type of intervention to prevent viral entry into cells, a different type of intervention to prevent viral replication. We're still struggling with long COVID. What happens to what I call COVID-induced proteinopathies? And I think that'll be our struggle going forward into 2022. When we look back at the vaccinations, you really have to consider here's a pandemic that occurred to the world January 2020. And then by summer of 2021, we've turned the corner for many countries with vaccines and have the prospect of being able to provide vaccine to people worldwide to convert it to endemic. So we've done that in 18 months. It took worldwide cooperation, despite all our problems with it. It's really an amazing human accomplishment that we can grow from. But we do have the problem still of our solidarity and subsidiary. How are we going to go forward? How are we going to reach agreement? How are we going to share information? That's what's so valuable, at least for me personally, with this group. And I think we can share with our colleagues and students is a task how do we help learn from the behaviors and gain solidarity so that we can work in concert.
Yeah, Professor Joe, the problem was countries around the world actually look to United States as a savior. And that is for many of the well-developed countries. But in many ways, they actually did not stand up for what they believed. And even now, if you look at, President Biden, he doesn't talk much about doing for other countries. And it's very strange to see USA being inward looking when it was a country that was always outward looking. So
it's very disappointing, and disappointing that it's continued. This has been a very scary time. I grew up in the 60s. I grew up during Vietnam. I was in college during Nixon. But until December, I thought we had seen the worst in the past. But we're still in a very, very dangerous time. There's high probability we're going to regress back to situations as bad as 2019, 2020.
All right. Thank you very much, Professor Joe.
Okay.
Professor Shabir is from Canada. Professor Shabir. Professor Shabir is also the president of the Canadian Academy of Geriatric Psychiatry. Professor Shabir, Canada perspective. A little confused about Canada. I don't know whether they are in which part of the wave and what exactly is happening, because we're not sure. Is there? Can you just enlighten us regarding Canada? And
absolutely. I hope I'm audible.
yeah.
Joe spoke brilliantly, and I think he kind of very effectively defined the problems. And North America is not very different. What we did have was a bit more in terms of stability with leadership, a bit more predictability and less of rhetoric, which did help, as we all know that good leadership makes a huge difference. The issue that we face in Canada is the loss of faith in the medical system by certain groups of people, very similar to what happened in the States, what's happening in Europe. So physicians didn't necessarily get beaten up the way they did in India, because that's more socio-political, not specifically related to the pandemic. It's just that it brought some things to the fore. But in Canada, we had physicians being attacked, hospitals being attacked by people who felt that these physicians were, within quotes, promoting the vaccine. What it basically showed us is this complete breakdown internationally of trust, whether it's with WHO, whether it's with the FDA, questions being raised about academics, and sometimes quite rightly so, because we know that many people work in cahoots with pharmaceutical companies. But when it came to the vaccine, the endorsement by many physician groups basically spoke volumes to the belief that this was not created by the 5G problem. People started saying it was a 5G network that was creating the epidemic, which was ridiculous at the face of it. But now we've come to realize you can make absolutely ridiculous statements and people can believe in it because of the media, the way media works. So where we have failed as physicians, both in Canada and internationally, is we fail to realize the incredible reach of social media. We were so slow in the uptake that people hijacked the movement. People actually hijacked it for political reasons.
I think that's the actual word. It was more of a hijack in all levels when it
Unfortunately,
came.
Yeah. And we had leaders who fed right into it for their own political aspirations, which was so sad to see. But that's a different story altogether. But like Baroness Finlay said, there are things we learned from what has happened, but we really need to evolve. And so if you look at the story from Brazil, I don't think Brazil is an isolated example of what has been going on. We've had small pockets in Canada where the vaccine rates are extremely high, but the politician who represents the riding was very anti-vaccine. It's fascinating to see that. So we are in the fourth wave. We've done not too badly. We don't have as much mortality at this point in time. The vaccine uptake has been fairly good, but unfortunately, when evidence came that the efficacy of the vaccine waned, and you had a seminar where you had absolutely brilliant, you had a fantastic presentation that day. I think it became abundantly clear that we're going to need the booster dose. Canada has been very, very slow in actually looking at rolling out the booster dosing, and we are still focusing on certain segments. Now, obviously, we're looking at getting the children vaccinated, younger children vaccinated, and things like that. But there's still this big, big hurdle of how do you convince people to take it when they're questioning the medical system.
Yes.
So I like Joe's points, and I like the fact that the team that's in here is actively looking at whether we can learn from these experiences, but also create solidarity in how we can tackle the real problems we're facing with social media and how we can get good, trustworthy information out there. But I think we are definitely in a much better position when compared to the States in terms of vaccine uptake, in terms of rolling out some of the programs, but we're still very slow when it comes to recognizing the need for booster doses.
Professor Shabir, there's a question from Baroness Finlay. It says, how has made MA, the small I and D, affected the way COVID has been dealt with in Canada? Can you expand that for us, Professor Shabir? MAID, for our audience.
Medical assistance in dying. This is actually a fascinating question because there are so many dimensions to this. And the first thing one is stuck with is number one, the government did put a stop on approving many of the maids because of the number of cases that built up. It's very interesting. So many people actually were signing up to it. In terms of the impact, and specifically to the Baroness question, we still haven't really studied the direct correlation between the pandemic and the outcomes in terms of people signing up for MAID. We really haven't done that. And like Joe basically touched upon in terms of the long COVID, we are seeing really complicated pictures of people who have had COVID, both cognitive deficits. In fact, I had a lady who would interestingly get angry only when she stood up. I've never in my life seen a case where a patient gets angry when they stand up. It was incredibly difficult to explain, both from the pathophysiology point of view, but the psychodynamic point of view. And she says, Dr. A, I'm fine when I lie down. Why am I getting angry when I stand up?
Orthostatic, probably.
We thought of POTS. We thought about whether there is, but we couldn't explain it as to why there was such a strong behavioral component. We also looked at the number of patients who are signing up for MAID, and Canada obviously is one of those countries that did embrace it, and now they're trying to open it up to look into mental health, schizophrenia, and things like that. We're worried that with COVID, long COVID, patients who've had significant mental health morbidity may sign up to it. Yeah. But there's also evidence showing that patients who are on psychotropic are actually protected. So fluvoxamine is now being repurposed for use in COVID. So Baroness, this question is such a challenging one because I honestly cannot speak with conviction in terms of what it is that COVID has done to affect this. I honestly cannot because we still don't have the data. But I agree with you. It's something we probably need to look into.
Yeah, to look into. Yeah, interesting point. Thank you, Professor Shabir. Thank you very much. We have Jasna, Miss Jasna.
Yes.
Jasna, Jasna has a PowerPoint presentation, so probably you'd like to. Yeah. Thank you very much. Go ahead, please.
Perfect. So hello to everyone. When we look back and look forward, I would say that I have very critical thinking for all the situation over the world, not only Europe. And I will try to explain all failures of the health diplomacy to communicate COVID, even I'm the part of health politics. So the health diplomacy in a rising field, the merges foreign affairs to medicine and law, and there is a focus on negotiations that impact the global policy environment of the health. Successful health diplomacy relies on political and diplomatic experience and must be combined with the public health knowledge and the evidence-based medicine as a background. It plays a vital role in sharing information, which makes a difference from successful and unsuccessful communication. And the core principles relies on the concept of bringing nations together, what is really, really important in diplomatic missions to confront any public threats that all countries need to prepare for. So that is the situation what we're dealing all together. The pandemic warning system generally from political administration failed when SARS-CoV-2 unexpectedly hit the world. Although lessons were to be learned from emergency preparedness and response to HIV and Ebola. But the COVID-19 pandemic has demonstrated the vital importance of global solidarity to confront common public health warnings. Despite the expectation, what was very high, of course, and the responsibility of WHO is supporting all countries to respond in a coordinated way and to bring together decisions aimed to jointly address the pandemic. It has enormous global impact and has led to substantial misunderstanding worldwide. So there is a communication issue from the beginning, of course. And what is the very important, in my opinion, the biggest communication issue, it was reported that there is no presence of human-to-human transmission, which caused a delay in implementation of public health measures like wearing a mask, keep social distancing, and taking the situation seriously. That is really evident. We have evidence of this, of the beginning of the pandemic, what was the very big mistake. The protective measures then varied among the countries and caused global distrust and protest when wearing masks became mandatory. Without the United Nations guidance, countries imposed the quarantine and social distancing measures of their own practice, and that actually concerns the implication of enforcement of the Universal Declaration of Human Rights. And there are many complaints in the human rights regarding the pandemic in total. And since then, a reliable source of trustworthy information was very, very difficult to obtain, as every country government provided the public with their personal perspectives, personal opinions. There were no universal strategies. Decisions then were mostly made by the experts in the Department of Civil Protection, which were represented then as national heroes. And the points of view needed both the citizen from one part and the professionals, especially health professionals from other part. Then the next information, what we could see in the public, it was the treatment for the COVID. For example, procedures with the hydroxychloroquine as a compassionate therapy of COVID-19 show, of course, the rise and fall. We have some clinical observation studies, and then other studies that in the end they didn't agree that this is the useful. And of course, this is also very, very a big misunderstanding about the treatments in the hospital. After that, we in Europe, the French authorities warned against the use of ibuprofen in patients with coronavirus disease, and afterward, this was denied again. One information to confirm, one to deny, and also there is evidence of this from Ministry of Health. Of course, the Europe didn't help the other countries, and we are very aware of that, me personal, because the Guardian reported of India's COVID catastrophe by witnessing a crime against humanity and was seeking help. There was a very big human declaration issue. It should have been thought that the problem could not be solved without considering helping also the other low-income countries, especially with when the vaccines developed and the negotiation process in delivering vaccines started, but without equal distribution globally. Then we had awareness of the vaccine distribution, and following the awareness of the side effects when vaccines grows. And the bigger problem, Lou, there's many millions, practically all have been depending on it. It's been one step forward, two back for AstraZeneca, for example, because reports from German economic newspaper published the top story that AstraZeneca vaccine apparently has an effectiveness of only 8% in elderly. You can imagine this information once when you publish something like that, to trust again, it's very difficult. And just a few days later, BBC reported that the most adults under the age of 40 will be given alternative to Oxford AstraZeneca vaccine due to an association with rare blood clots. So two contradictory information made an absolutely mess. Then Canada and Germany joined to Iceland, Sweden, Finland, and France in recommending against this vaccine used in younger people who seems to be a higher risk for developing the clots and are less likely to develop severe COVID-19. The Goethe University in Frankfurt in Germany highlighted that the approach makes sense given the other vaccine are available if we don't have just one type of vaccine. So that they wanted to mix different types of vaccines. In the Europe, the Medicine Agency says that it's not yet clearly what the risk factors are, and that is, of course, very, very big mistake in the communication. And there was also report of the side effects after other types of vaccine, of course, Johnson, Pfizer's, and Moderna. Following several cases of individual accidentally vaccinated with two different vaccines, what was the case? It was presented to the public that all vaccine does not to be the same to provide an appropriate level of effectiveness. And not long afterwards, some countries have adopted an unproven strategy. What is the, let's say, some experiment? The switching shots might stream believing that it will be extremely likely that mixing vaccines will still produce a strong immune response. And any of this public information has not been officially confirmed or denied by coordinating authority, and it leads to complete vaccine mess and allowed what we can see now space for anti-vaxxer movements to flare up. And now we're dealing with some countries, they're vaccinated only 50%. Each country then adopted instructions of safety, implemented the age limit under 30, 40, 50 from their evaluation without guidance from the top, from the health authority. In the same way, practically, as they organize the healthcare without common opinion and uniform strategy for hospital management regarding the guidelines for the chronic patients and protocols for their treatments. And questions after that have arisen about who is the main coordinating authority, as the World Health Organization cannot overrule the Center for Disease Control and Prevention, because they are separate agencies. Both make a recommendation based on the expert advice. The CDC relies on advice from its internal experts, while the WHO convenes panels of independent experts from over the world. So we can see that both are important to share decision making. Then in the hospital settings, it's really critical now to review the shortage of guidelines and protocols, what I mentioned, sent to the hospitals for disease control for non-COVID patients. Because doctors were not given clear instructions on how to organize healthcare, and at the same time their responsibility was sought, nonetheless without any national support, without possibility to call someone, to ask something. But no country, hospital or clinic can keep its patients safe unless it keeps the health workers safe. I want to say that as a part of health diplomacy, we need to protect the doctor first, that they can then protect their patients. That is my main motto of my work. The numerous hospital departments were completely empty, for example, while the COVID departments work doctors from different specialties as psychiatrists, ophthalmologists, and other. And that is a difficult thing to work in these new settings, and that lead also to burn out. In the face of incredible efforts to provide for care for the patients putting themselves at risk, it definitely consequently resulted in a completely burnout syndrome of health workers, and that is a very serious thing that we need to resolve. Sometimes the situation, especially on the beginning of the pandemic in Italy, I was present in Bergamo where everything started in this part, let's say like this, and it really was a very big effort to save the lives. The growing awareness of ethical and social determinants of health has also made international health negotiation increasingly political, diverse, and multi-sectoral. Then introduction of Corona Pass or COVID Safeguard represents a very big ethical and legal minefield, and dilemmas how to use it. Because the bioethical question is the logic behind the Corona Pass, which excludes people from social life because of their presumed health. So many countries now use the QR code for entering in the restaurants, in the theater, in the also on at the work, especially in the hospitals. For example, in Italy and Belgium, the Corona Pass is mandatory, and you cannot enter in any part without that. So that is a very big issue, especially because it's not only QR code, it's all data there, especially if you if you are vaccinated or you are being recovered from the corona. And although it has undoubtedly a safety value, because maybe we can be more protected with that. Even now we can see that with this Corona Pass, that is still a transmission of the virus. Also, Corona Pass can be criticized from a legal point of view that will create discrimination. Accordingly, the Taos privacy security law, it's absolutely something what we need to care about this. And there is also rising complaints to Court of Human Rights regarding data protection regulation. The outbreak of COVID measures taken by the government and public authorities raise several challenges, issues for employers, because now also employers, especially the hospital settings, they don't have enough personal staff to work. If you can limit this one who doesn't want to take a vaccine. And then the announcement of reopening borders and traveling to and from abroad raises awareness of safe, free movement as well, because now we can see the still problems from United States and Europe and the Australia, for example. There is still a very big issue with the cross-border measures, and the information changed from a day to day, which particularly affect and tourist countries, and we saw this summer. The fear of COVID restrictions still continues to dominate, especially regarding COVID tests on the borders. And what is the real test, PCR or also this antigen fast test? There is still a misunderstanding regarding this. But to conclusion, responding to emergency, whatever the cause, presents a very big challenge for successful world health management. Diplomatic rule of control emergency operation is unique, and only when politics admit mistakes could learn from them. And as a result, when it comes to planning ahead for positive outcomes, we should be ready to face the new threats and sustain public confidence. That's for now from me.
Thank you, Jasna. Yeah, thank you very much. It's really, I think if there's any, right now, when we're talking about health diplomacy, this COVID pandemic has actually shown the breakdown of health diplomacy in all ways. And our problem right now is the vaccine passport and, COVID passes. That is what is the problem now. And of course, boosters. What you said was very important. Two bodies who are responsible for giving information regarding COVID, that is WHO and CDC, when they contradict each other and they are in conflict with each other, naturally, how would we expect the public to actually trust the profession? So that is where the problem happens. A lot of pride and a lot of, this is what, of course, politics played a big role too, especially in individual countries where politicians were dictating terms when it came to, vaccines and policies and, those kind of things. But now, really, our challenge now is the booster and the COVID passes. That is what we're dealing with right now. Jasna, really thank you for such a beautiful and very lucid and pertinent presentation. So thank you very much, Jasna.
Thank you.
And Angelique, Professor Angelique, Dr. Angelique, you're having issues with
your camera. I've just been here.
Yeah, because you did say you're having problems with.
Yes.
Yeah.
Thank you so much
Yeah.
for inviting us again and to speak on this extremely important weekly Sunday webinar and information series. Sitting here and listening to each and every one, I just again realized how deep in trouble we are and what COVID actually showed us. In a way, COVID did us a favor, because now we need to start to address problems which we knew were there in the past, but never actually addressed it. We just work over it and carry on with our lives. So Jasna actually said a lot of the things that I wanted to say, but I'm going to stress again the lessons. The lessons that we learned so far is mainly around education, as some of the speakers mentioned it, behavior, because behavior and education between doctors, scientists, government, the public out there, behavior patterns, to understand that, to make it easier for the scientists and the doctors and the clinicians to decide what might happen, where are the problems, then perceptions, a lot of misperceptions out there, and this can be directly come back to poor communication. We saw that communication is so important. It is communication between National Department of Health, the public, the healthcare, in between. Everyone needs to be listened to, and the communication should be clear out there. Jasna mentioned the importance of the WHO and the CDC. If they struggle, and again, how do you think would the average person in a country out there who doesn't even know or have the background and the medical knowledge that we have, how do you think they see us? They see us sometimes as fools that doesn't know, the right hand doesn't know what the left hand is doing. And why should they then listen to us? And I think it's extremely important to get that knowledge sharing out there in the right communication platform. Something that we also saw is that between scientists and specialists, especially and clinicians, and especially those clinicians at front, we almost call them coalface, first of all, seeing the patient, getting that patient into the surgery. And it's normally a general practitioner, or it would be a nurse. There is a huge problem there with protocols and clinical guidelines on how to help and assist at that level. People, it's easy once if the patient has been admitted to a tertiary institution. That's easy. You've got everything at hand. But when you're sitting in a primary healthcare setup in a small town far from everyone else, there is no proper guidelines. People are still fighting about ivermectin, about chloroquine, about whether they should steam with peroxide. I mean, it is a nightmare out there. And then we expect the clinician to treat a patient with barely clinical knowledge and skills and the bare minimum, because you cannot admit, there's no place to admit. You have to suffer with the patient and getting them sorted out with all this discrepancy with guidelines and who knows the best. But forgetting that there's a primary healthcare, there's a doctor out there in a rural area. Then it opens up our eyes to corruption. There's a lot of corruption going on that needs to be addressed. We saw the difficulty with vaccines, the logistics around it, how to get people back for their second dosages. Again, the booster in South Africa, we are now going to start with the doctors and healthcare workers who received Johnson & Johnson in the beginning of this year. In February, we are now going to start vaccinating them with a booster shot, a second booster, or whatever you want to call it, a second dose of Johnson & Johnson. We start on the 8th of November. We will be starting with them again, because we have seen that during our third wave, that the efficacy is less. We get a lot of breakthrough infections, and we cannot afford that. Then, extremely important, the fact that governments or politicians are interfering into healthcare. We in South Africa, from South African Medical Association, have stated many times, politicians should do what they do the best, stick to the politics, leave the healthcare to the scientists and the clinicians. Let us lead them going forward. But once if you get politicians trying to think that they understand healthcare and just abandoning advice given to them, it becomes a critical problem. And then again, you will lose the average public out there. The public are not stupid. They sit and they listen, and they see the fights going on. They hear that today we are saying one shot is enough. You're not going to get very sick. It's going to protect you. And then tomorrow their friend died. And they don't understand, why didn't we say it is protecting you 94%? There's always someone that might die. We need to be careful how we communicate with the people out there, because we need their trust. And if they can trust us as clinicians, then we can move forward in trying to get people vaccinated. Also admitting that vaccination is not the silver bullet, but at least it's going to help us to get through this pandemic. With these few words, I just want to say, I sit nearly every Saturday morning on the Simao group, and I find it also very, very enlightening. And I think it is important that clinicians from across the world speak with each other, because in the end of the day, a patient is a patient, and we all struggle. And I think we can admit that we struggle, and the way forward. I also need to say that there was a study done recently in South Africa regarding the state of mind of the healthcare workers, and it was found that between 35 to 49% of healthcare workers currently are suffering from PTSD. Okay. And PTSD is bad. But I want to thank you again for being able to voice and raise some of the concerns, and hopefully we can move forward. Thank you.
Thank you, Dr. Angelique. Really nice to, we wish we could have seen you, but nice to hear you from South Africa. We'll move on. I think Dr. Lincoln is not there. Sorry, Dr. Leon is not there from Kenya. So our last speaker today is Professor Alvin. Professor Alvin is from Hong Kong. He's a pediatrician, and he's part of the Hong Kong Medical Association. Professor Alvin.
Thank you. Can you hear me?
Yes.
Thank you very much, Professor Mary and Professor Russell. Thank you for allowing me to participate in this very meaningful discussion. And in fact, just now, Angelique and also Jasna had given us most of the food we need for the discussions here. And thank you very much. And I think in Hong Kong, we really experienced also the very unique problem of our pandemic this time is that our scientific data had changed very, very quickly. And so we often have very conflicting advice to give to the public concerning our health measures and the education for the public. And that gives us the trap to attract distrust from the public. For example, I still remember last year in February when the WHO, the USA, UK, Europe, all were advised against masking. And yet Hong Kong, because of our unique experience of the SARS 17 years ago, we very early had the experiments that demonstrated the usefulness of mandatory masking at that time. And so at that time, we are, the medical professionals were against all odds to advise the government to have the regulations to restrict the freedom of our citizens of wearing a mask. And so at that time, we did succeed to advise the government to change their mind. At first, they followed the advice of WHO that putting on the masks are not necessary. And because, you know, we had been a British colony for 150 years. And so the Royal College in UK have been very influential in Hong Kong. And even from the Royal Colleges at that time, they had given the advice not to put on masking. And so at that time, we stood fast, stand fast on our position. And the government eventually changed their mind. And they gave the policy to the public last March that we should put on the mask. And yet, similar things have been so conflicting all the time. So we could see that sometimes we said that Well, in the past, we did change. Say, for example, in the past, we say that hypertension is 140 over 90. And then last 2 years, we changed it to 120 over 80. And in the past, we said that don't eat eggs so much. That will increase our cholesterol level. And then a few years back, the cardiologists again changed their mind and advised us, oh, no problem. We can eat many eggs and that won't affect our blood cholesterol. So our public, in fact, had the experience that we medical people or the scientists could change our mind. But that was over 10 years or decades. That they knew that we had changed because of accumulating scientific evidence. But this time, sometimes within a few months, we change our scientific opinions and advice to the people, and the people get confused, and this give food to their anti-vaccines people to attack us. The many KOLs in our communities based on pseudoscience and rumors. And then because of our changing views too often, and they attack us. And many people believe in those KOLs with pseudoscience advice. And in fact, we followed the steps of Australia. We are now enacting laws to punish those who had spread fake news or rumors. In Australia, they have been very good. I read from the news that they would even deregister the doctors who spread anti-vaccine messages around. That is very stringent. In Hong Kong, we are now enacting laws that if people are spreading fake news, they could be punished. But anyway, we doctors had our own limitations. We're based on science, but sometimes the scientific information changed so much. And in this pandemic, the WHO or the USA have very frequently passed emergency use of the vaccines, for example. So the anti-vaxxers will always attack us. The scientific research is not mature, is not long enough, and is immature, and people are receiving vaccines that could have long-term side effects that we don't know, etc., etc. So it's hard to defend sometimes for us. But then so that's why I agree with all of you that solidarity is so important, and we doctors should be together, and we should stand firm on the scientific evidence, and we should really continue with our tradition that publication in international journals should be the golden key, that the scientific reviewed evidence should be the basis that we follow. And so the third, say, for example, the third phase research of any new vaccines should be published in the journals before we issue the emergency use of those vaccines. But of course, sometimes things change so fast, and I understand that although I agree with Angelique or Justin that we should not mess up with the politics, but we still understand that politicians rule the country. They make the policies, and medical professionals are experts. We give advice to the politicians who made the policies. So sometimes they are against us. So it is for us to make our lobbying, the negotiation with the government to be effective. And so to be convincing to them, we need to have very good proposals and evidence-based, and also taking into consideration of the other benefits of all the stakeholders. I think this is quite a complicated process. In fact, in the discussions in CMAO or in WMA, I could see that most of the issues are social, economic, or ethical, and that had been, merging with the sphere of influence of the politicians, and that's quite inevitable. So I was very frustrated, just as Angelique had said just now, that very often our scientific views, our medical advice given to the government were not taken. They just turned a deaf ear to us. So we were frustrated. But on the other hand, just like what I had said, because the medical evidence have been changing so frequently, and we often have to base our action on some transient or changing evidence. So I have to accept that sometimes the government or the politicians don't really accept our evidence, our advice. But anyway, I hope that the WHO and the world authorities are really making sensible decisions. Say, for example, in Hong Kong and in our country, mainland China, we still keep the zero tolerance policy, in contrast to most of the countries now adopting and are coexisting with the virus attitude and policies. So we have to balance. In China, in Hong Kong, is concerning about 1.4 billion people. And we had the very tight rules and restrictions. And in Hong Kong, we all suffer. We could not move out, we could not travel, and the people could not make business with international relationship. And yet, this is the politics. They made the rules, the country made the decision, and we have to follow. And but in fact, for the whole world, when they are allowing the pandemic to become endemic, so just Hong Kong and China wanting to keep zero tolerance is very difficult, in fact. And so we have to balance between the totally polarized policies in this world. And for me, I would think that our aged citizens only have 40% vaccination rate. And of course, this is because of the vaccination hesitance and then the fear of the side effects. Because just at the beginning, Norwegian experience has shown that many elderlies had died from after vaccinations, and many had expanded this news. And so many family members were so scared that they did not sign consent for the elderlies to get the vaccines, because the elderlies need the consent of the family members to get the vaccination in the aged homes. So our vaccination rate in the over 70 years of age group is still very low, only 40%. So if we open the border, these vulnerable, high-risk elderlies without vaccination will be dangerous, and our medical system could be overwhelmed, and we would really face the difficulties. So I appreciate why the government will still keep the border closed and don't allow the policy to live with its coexistence with the virus. But on the other hand, we are also frustrated. Why can't we increase the vaccination coverage like Singapore or Australians? They had increased the population overall vaccination, and especially in the elderly age group, they had increased the coverage so successfully. And yet in Hong Kong, we still failed to do so. So we are still thinking how we could be smarter, like the Australians and the Singaporeans, to jack up our vaccination rate faster. But unfortunately, this is something political. Many of the citizens reject vaccination because of political reasons. So I would think that in Hong Kong so far, because of the zero tolerance policy, we had very low infection rate for the past half a year. In fact, very few. And yet we suffer so much economically. And so we hope that in the future, a few months, when the Chinese population in the mainland, they had reached 85% vaccination coverage rate, then perhaps our border policy could change a little bit, even when we still could not have the elderly population vaccinated. But anyway, thank you so much.
Thank you, Professor Alvin.
For all your input.
Yeah, thank you. Thank you for all that information that you provided regarding Hong Kong and China. I'm just going to wind up this session with just one question, which I will ask Baroness Finlay regarding the influence of politics on health, and how is it that the politicians are getting away with it, and the medical profession is suffering in the consequences? Have we actually lost our voice? Do we actually have a say in all these health policies? That is what is important, because looks like the doctors are now subdued, and they don't seem to have a voice now. So
I think, thank you very much. Is that to Alvin or to me?
Alvin shared his views on politics in China and Hong Kong.
Yes. Yes.
I will ask this question to all. So
okay, so
yeah.
I'll try and be very short. I actually think that our role has to be to present politicians with the evidence that we have, and we have to have the courage to stand by that evidence. We don't make the political decisions, and we have to be prepared to speak openly when we disagree with the decision that the politicians have made. But the way that we present it has to be to the public, that they understand that medicine does not have absolute answers. I think that the magic of medicine, the mystery that our previous generations relied on, was somehow that medicine could do something amazing. And now the public have realized that medicine has a degree of error. So we're more honest with the public, but that means that we've lost the power of the mystique. And somehow we need to take the concept of probability to the public, and for them to realize that they have a responsibility to each other, which is where I think the role of public health medicine comes in terms of educating people about their responsibility to themselves and to each other, rather than looking to medicine for the answer. In terms of the politicians, they need to be given the risks, a risk assessment in simple terms that they can understand, because remember, a lot of them don't have a background in statistics and so on. So you are talking to lay people, presenting options, and it's up to us as the medical scientists to think through what the different options are and the different potential outcomes. And often that means that we have to abandon our own personal interests to think of the common good.
Yeah, thank you. Baroness Finlay, were you able to influence, or rather because you're part of the UK Parliament, you have seen, because Boris Johnson was, switching a lot when it came to policies. So what happened there actually?
Well, I think that actually medicine did have a voice, and our medical advisors did have a voice. The difficulty was that there were other people saying what they thought the public would or wouldn't tolerate. I mean, one example was that some of us were pushing very early on for lockdown, and were told that the public would not tolerate lockdown early, but actually, as it turned out, the public tolerated lockdown amazingly well when they were told why there was lockdown. Because at the end of the day, each person wants to survive. So there's almost the survival instinct in people kicked in. But the other problem, of course, is the media, and educating the media to put responsible reporting, not scaremongering reporting, but putting enough to empower people to do the right thing without creating panic. So we did have a bit of panic buying and so on before lockdown, but it wasn't too bad. And I do think that we did influence the way that politicians thought. And I think lockdown would have been even later if we hadn't been able to have a voice.
Okay, all right. Thank you very much. Professor Lincoln?
Yes.
Yeah, so a politician have the doctors lost their voice in terms of influencing politics and decision-making in healthcare?
Well, we try our best efforts. I already told you, we had some problems, for instance, in Nicaragua, and where the local government tried to criminalize the doctors. But I had a lot of documents from the medical societies from Mexico, from Honduras, from our Brazilian Medical Society, the Society of Argentina, Chile, and Paraguay. There, they stated something, or they put some suggestions. It depends on the country, and I would say in a relative success. Okay, as health was a subject of discussion of every table, every meal, yes, here every house, in Latin America. Yeah. So it's difficult for us because we speak in such a wide region. But
Bolsonaro didn't. The Bolsonaro didn't have. The president.
I consider we have some absences. Okay. Like I say, in Brazil we achieved the federal medical career. We struggled for it in 10 years, but now it's starting. Okay. Especially from the distant regions. Okay.
Yeah. Thank you very much, Professor Lincoln.
You're welcome.
Professor Joe, do we have a voice?
Medicine has a voice in the US, but it's not a single voice, which is a huge problem. We all see our different areas. And so a lot of times when you see physicians who are backing up the politicians, you find their background is in health policy and not in public health or in taking care of patients. I think overall, though, it's still the individual physicians still carry a lot of weight with patients that they take care of. The resistance has always been there. And I think people see the sacrifice that the nurses, the healthcare workers, the clinics made, and that carried a lot of weight. So you may recall the president said the physicians were making money off the epidemic, and so they were making it up, that it was a fantasy so that the physicians could get rich. I don't think any significant portion of the population believes that.
Okay. All right. Okay. Thank you very much, Professor Joe. Professor Shabir, Canada?
Well, in some ways, medicine has lost its credibility. And we have unfortunately recognized that the media is really not very honest, and there's often an agenda. We've known that for years, but it's come to the fore. We've also recognized that there are individuals within the medical field who wish for political position and power, and they will always undercut and sell medicine. But the vast body of physicians, and this is so beautiful to see, actually get together, just like this group. We get together, we challenge what's going on, we reinforce the solidarity with the truth and science, and we rely on science. We are not here because of personal motives. We want to promote good science. So in some ways, yes, we've lost some kind of leveraging, but it has reinvigorated the good physicians to review both our presence politically, hopefully in the social platform, but also in being able to reach out to patients with a lot more gentleness and kindness in trying to educate them about the current standards with medicine.
Yeah, thank you very much. This reminds me, just came to my mind. I was invited for a talk on sex trafficking, and in that platform, there was one of the journalists there. Her name is Faye D'Souza. I think those who are Indians know about her. She was one of the very outspoken journalists who finally got kicked out from the channel, and now she has her own, YouTube. So when I did meet her at that time, she was very anti, a doctor, and she was telling me how the same things what all of you are saying. Doctors are making money out of this, and I said, Faye, I'm a doctor. Can I tell you the problems that I see every day? Do you know what the problems doctors go through? And after talking with her, she changed, and she actually donned on the PPE and went to KEM Hospital. I think many of you know KEM Hospital in Mumbai is a government hospital which actually you'll see patients lying outside the hospital because there are no beds. And she went in and she saw how doctors were actually working during the COVID pandemic, and that actually changed her. And now she's very, pro doctors, and she talks about the difficulties that doctors have during this COVID pandemic. So I think, like Professor Joe said, individually, we all can make a difference. We can, even though the media may be a little, they want to sensationalize practically everything for ratings, we can do our own bit. So I think it's always good to talk to the public and educate them, like Professor Shabir said, in a gentle way. So I think all of us have a role. I'll just go to Jasna. Jasna, would you like to add to this?
Well, yes, I want to mention my working process, for example, always include the opinions of doctors. And there is why I want to highlight something, because there is a difference between doctors working directly with the patients in clinical settings and these others who are the managers, hospital managers. They don't have patients directly. And when I take the opinions and when I want to see actual situation, I always call these directly working with the patients, and this is a very big difference to how is the situation from them who are really exposed to all decisions for the patients directly.
Yeah, thank you, Jasna. Thank you, Angelique. You've made a very interesting statement, so we can probably wind up with you. Angelique, would you like to?
Thanks. Yes, I think we do have a voice, but we have also seen and learned that our colleagues, they love to discuss it between colleagues. You will discuss it in the tea room, you will discuss it in the theater, but very seldom will you see doctors stand up out there in the media. It's just not how we are trained. So this, unfortunately, then only comes down to a few doctors that need to that is leading the voiceless, if I can put it like that, the voiceless profession out there and present them in the public, on governmental platforms, anti-vaxxers. If I can tell you how many anti-vax hate posts I get, I think it's laughable. But that's unfortunately what it is. So we have a voice, but it's a difficult thing. It's like a full-time job.
Okay.
Because the moment you want to raise your voice to say something, you need to get your facts right.
Yes.
Otherwise, you will be attacked. Thanks.
Yeah. Thank you, Angelique. Very well put. Professor Alban, one word, one sentence, and we will end this. Can you hear us, Professor Alban?
Yeah, thank you. I have to unmute myself. Yeah, I think it's important that the world should be equal. And I think the developing world should get more of the vaccines. And I hope that medical associations all around the world should cooperate with the WHO to ensure that the vaccines could be distributed to those with little resource, those countries with a little resource. And so Hong Kong had just donated 7.5 million doses of vaccines, AstraZeneca. But then I think it's just a drop in the ocean because the world's so big. So I think I do agree with WHO that this is a pandemic, that is the whole world is suffering from it. So we could not just center in our own nation, our medical association. We should all contribute to the whole world's need of the vaccines. Thank you.
Yeah, thank you very much. It's been a very interesting discussion and lovely to hear from all of you. Very interesting points. I think we have learned a lot. If you all don't mind, I just want to ask Professor Rizwan Taj from, he's still on. Professor Rizwan Taj is from Pakistan. Is he on, Derek? Or has he logged out? Because he was there, and yeah, I think he's not there. So thank you.
No, he's not there.
He's left. Yeah. Thank you very much. It's been a wonderful discussion. Thank you for taking the time. This I know all of you are, are very busy in your schedule, but of course, obviously, this has been a learning curve for us, a learning point. We all feel like we are in this boat together, and we can come out of it successfully. And really nice that we can come. Now it is every second week, every second Sunday, to share our thoughts. So thank you very much. Thank you to all our participants. They have stayed on to listen to all of you, and some of you can read the comments if you like. I'm sorry, we won't be able to take any more questions. So I will hand it over to Dr. Russell if he is awake. Dr. Russell, are you awake?
Yeah, well, I'm awake. It's 1:30 in the morning. But look, thank you very much, Mary. But I feel that I just should add to you. We heard a lot of the whole world, but I want to just give you a briefing on Australia. Alvin did mention Australia. There's a very interesting story here. When we started, that's 20 months ago, Australia locked, the country was locked. It is still locked. Okay. So they closed the country completely. So we had relatively very good deaths and so forth compared to the rest of the world was good. But complacency took place, and it was almost, I have to say that from the medical perspective, the AMA took a very active, the Australian Medical Association was always there, was accepted, was given took a big role. Now, at some point, Australia was so comfortable that because there was no virus, everyone was living a life fairly normal, that they did not worry about the vaccines. And then, of course, came the Delta, which turned the whole story around. And then we become a country that was divided. So we have today, and I have to say, the good thing, we have Australia, 3-4 states have no virus. The borders are locked, and not only you can't travel out of the country, you can't travel in the country too. Okay, but the good thing is that this led to the revamping of the vaccine, and rapidly, I just note, Melbourne, Victoria today has reached 80% of the 16 and above. Getting vaccinated. Sydney reached, New South Wales reached it already, 2 weeks ago. The Australian Capital Territory has reached 99% of the population vaccinated, right? So they've opened up now, and the country itself is probably around 70% but they have opened, and they expect by the 23rd that 90% will be vaccinated. Now, the other important thing is from this week, the booster started for 6 months. So if you finished your vaccine 6 months, the booster is coming now. So we have opened up, and from the expected from the 23rd, everything is going to be similar to pre-pandemic apparently, and the country is the borders are also going to be opened up. I think this week or next week, all the international borders are being opened up. So that's where we are. Then 80% of the 12 to 16 have received their first vaccine, their first dose. And I think December they start the 5 to 11-year-old. That's just been approved by the TGA. So here's a story of good. Then we had this terrible period. And of course, it's still there. But again, the three states, at least New South Wales and Victoria, which is 60% of the population, have reached the 80% of vaccine, and they are opening up fully at 90, which they expect on the 23rd of November. That's, for me, it's already November. I'm already in the 1st of November today. So that's a little update on where we are in Australia. So we had a lot of lockdown in Melbourne. Is the world's most lockdown. It had 260 holding the record for whatever, for many reasons. But the AMA took a very important role. The doctors did listen and did give a lot of importance to them. And to that extent, the deaths have been relatively to the rest of, or to many of the other parts of the world, has been low, or comparatively low. That was probably because they listened to the medical, the AMA and the doctors had a big input into that part, and that's probably helped to that extent. Okay, that was just to bring you up to date. Having talked to the rest of the world, I thought we should have a little bit about Australia, where I'm sitting down and where we are. So we all agree with this. That was a question asked here. We have all opened up the boosters. In fact, started for all vulnerable. I think about 3 weeks ago, and from last week, it's become now all the population is, as soon as they have their 6th month, if they've completed 6 months, then they have to get the booster. Now, the question came up on, is it correct to have your 3rd dose? And we're using now, we started with of course, AstraZeneca, then went to Pfizer and the Moderna, the Pfizer and Moderna. So now that's what they're using, and there's now suddenly there is a lot in excess of that. Of course, they are donating vaccines, and I think they're manufacturing the AstraZeneca vaccine, continuing and going to be giving. They are giving it to the Pacific region, I think. So again, there's an ethical issue here on the 3rd dose being offered, and yet some parts of the world have not had their 1st dose, as Dr. Ravi did bring up from the WMA, has been concerned about it. I think many people, many here, including the AMA, have brought that issue about the ethics of bringing a 3rd dose in before the rest of the world. Many of the people in the world haven't had their 1st dose. So having said all that, I want to thank you now. Thank you all very much for joining in. It's been an interesting update. We will continue. And thank you all for your not only all our participants who have come from all over the world, but even many of our panelists around have been there. I want to thank all of you, and we continue to build global solidarity, as this today demonstrates that solidarity, cooperation, and reinforcing that we are all in this together, and we will come out of it together too. So once again, thank you all. Thank all the panelists, Baroness Ilora Finlay, Dr. Ravi Venkateka, Professor Lincoln Ferreira, Alvin Chan, Angelique from South Africa, Dr. Joe Thornton from USA, Dr. Shabir Amna from Canada, and Jaffna from Europe.
Angelique?
Yeah, I did say Angelique. Yes, she's been not only Angelique has been bringing in South Africa we've had South Africa all the time due to Angelique. Thank you very much, Angelique, for your.
Deborah wants to say something, Dr. Russell.
Yeah, and so I want to thank these speakers, and of course we do thank all our other colleagues who have been here all along. Yes, Deborah from Brazil, who's with us. Yeah.
Hello, good day for all. I want to congratulate all of you, the panelists and the organization team, for this excellent webinar with the great team. Thank you.
Thank you, Deborah. So there we go. So I think, Mary, that we have got the ethos. So the next one is 3 weeks, and it's on the students going to look at the impact of COVID on medical education, their medical education. And so the International Students Association and IFMSA are going to be offering pens. So medical students from around the world will come along and explain or tell us what their practical issues have been in terms of what in the last 18 months or so. So thank you once again, and we will see you again. Stay safe, stay well, and we'll see you in a couple. I think it's 14th next month. Thank you.
Thank you.
Bye bye.
Bye bye. Thank you. Thank you.
Bye bye. Thank you.
Bye bye.
Thank you, and yes, Prince.